Welcome back, everyone. We are going to head right into our final panel of today for the third annual virtual TSM conference, Redefining Recovery. As always, I am Jenny Williamson, Executive Director of the C3 Foundation, and I am so glad you guys have been with us here today. And welcome if you are joining us brand new. This conference is available to view and participate in for free, thanks to our two co-headline sponsors, RIA Health and Work It Health, and our panel sponsor, Deerhaven Gardens. If you would like to support the work of the C3 Foundation, there's a donation link in our profile, and we have a timer that'll drop a donation link in the chat during the broadcast. Also, if you're on Twitter, please feel free to live tweet our conference with the hashtags Redefining Recovery and Options Save Lives. It's a great way to amplify the impact of the conference and maybe even bring in some new viewers. Our next presentation comes from Dr. Adi Jaffe, who will speak about supporting TSM and harm reduction in online interventions. Lessons from the Wild, Wild West. Dr. Jaffe PhD is a world-renowned expert on mental health, addiction, relationships, and shame. He was a UCLA lecturer in the psychology department at UCLA for the better part of a decade and was the executive director and co-founder of one of the most progressive mental health treatment facilities in the country until he started Ignited, a smart, personalized, adaptive recovery system. Dr. Jaffe's work and research focus on changing the way people think about and deal with mental health issues. He's passionate about the role of shame in destroying lives and aims to greatly reduce the stigma of mental health in this country. In this context, Dr. Jaffe has used his personal experience as an incredibly effective, inspirational, and motivational tool. Dr. Jaffe, welcome to the conference. I'm going to go ahead and hide my video so that you can take it from here.
Thank you so much, Jenny, and welcome to everybody who's here. I don't get to see you, so I will be asking you to ask questions actively throughout the whole presentation. You know, I love the options save lives and the redefining theme for this year because I think that's what I've been trying to do for the last 12, 13 years or so. I met Claudia 10 years ago or so. And we've been together on this road for that whole time. And so I'm incredibly grateful for being here and for you attending. And I want to start out really with putting in context why it is that we're having this conversation. You know, there are millions of people who struggle with alcohol use issues. I'm not even calling it a disorder to start out, just issues related to alcohol use in this country. And as of right now, I will start sharing my screen. As of right now, about 95,000, almost 100,000 of them die every year from alcohol use problems. And that is from chronic and acute alcohol-related issues. And, you know, while the focus has been on opioids in this country for the last 5 to 10 years, alcohol has been one of the leading causes of death in the country for the entirety of that time as well. And just for reference, and when they sort of started keeping track of this in 1999, there were almost a third as many people dying, and in 2017, about 30% less. So, you know, every 16, 17 years, we were doubling, and yet we've added 30,000 more in just the last 5 years or so. And I think there are a lot of reasons for that, but, you know, just to keep it in context of what it is that we're going to care about here, that means about 380 people die every year due to excessive alcohol use. That's a big enough number where we should all care about anything that helps us reduce the deaths. And part of the reason I'm so excited to speak here is that's the part I'm focused on. So we already heard about harm reduction. Obviously, we're going to talk about the Sinclair Method as well. But just to put things in context, there are many people in society that want to help those who struggle with drugs and alcohol. And I think we would all agree that we can't help somebody who's dead. And so harm reduction to me, in the entire context of what we're talking about, I would argue starts out with the idea of reducing harm at least enough to keep somebody alive, because if we don't do that single thing, there's nothing else we can do to help them. And this mission is really personal to me. I don't come at this only from the academia, although, as Jenny mentioned, I got a PhD at UCLA, but the way I got that was a pretty roundabout way. So I used to struggle with addiction myself. I would say the last time I was actively struggling with it was about 20, 21 years ago, but it led my life into a dark pit, I would say, over time, a pit that got me disconnected from my family, disconnected from anybody who really cared about me. This is a picture of me during that time. I'm weighing about 124 pounds. While alcohol was not my drug of choice, I drank a lot of alcohol. My drug of choice was methamphetamine. But that's my dad, who would really come and visit very rarely, because I didn't really let anybody in my life close to me. I knew how bad my addiction was. And again, as I mentioned, I'm about 165 pounds sitting in front of you. I'm 124 in that picture. And, addiction took me really, really far down. And so the only reason I even ended up in school was because after this period, I actually ended up going to rehab, going to jail. And when I got out, I couldn't get a job. And so I got into academia almost by happenstance, just doing the only next thing that was available in front of me. And I'm grateful that I did, because I've gotten to meet some incredible people and make some incredible changes in people's lives over the last 12 years of doing the actual work. It took me about 7, 8 years to finish getting my PhD in the middle there. But one of the reasons that I fight so hard against the status quo, I'll say, of the addiction industry is that, as somebody who struggled with it myself and seen the difficult path, I also ended up learning about how few people actually make it out. And I'll talk about that quite a bit through this talk. But right now, instead of only identifying as somebody who used to struggle with addiction myself, I'm lucky to be a husband, a father of 3. Kai, my oldest, at 12, and Noah, my youngest, at just turned 4 a couple of days ago. As I mentioned, I got my PhD in psychology at UCLA, and I've written a book. We'll talk about a tiny bit later. The fact that I get to speak here has quite a bit to do with how non-traditional the way I look at addiction is. And I think in the C3 Foundation, in this talk, is actually probably a different kind of environment, a home of sorts, because Claudia and the organization have been doing that sort of work, that non-traditional sort of thorn in people's sides, I'll say, over time in the addiction industry, but speaking to the techniques that they've seen work and the things that they've seen create actual change. And so I've been lucky to be on pretty much every TV show and channel that I could care to be on over the last 12 years or so, speaking about these techniques and about a different way of being. And in that context, I wrote a book called The Abstinence Myth. And while a lot of people get confused about what the abstinence myth means, the thrust of the book are 2 different myths about abstinence. And the first one is that the only goal for anybody who seeks help with addiction has to be abstinence long-term. And the second one is that abstinence is the way to measure how somebody's success is moving forward in terms of their recovery. So 2 things: should we demand abstinence from everybody? And then should we measure success in recovery by abstinence? Now, I didn't start out as the guy who would write this book. I'll be honest. I went to a very traditional rehab. As I mentioned, I went to jail. Complete abstinence was the only option given to me 21, 22 years ago. And it was therefore the only option I believed existed. When I went to get my PhD at UCLA, NIDA, and NIAAA, so the National Institute on Drug Addiction and the National Institute on Alcoholism and Alcohol Addiction, were the prevailing ways that the research I looked at examined addiction through. And I thought I was going to be a professor. I thought I was going to teach addiction and really follow that route. And I was on that route. I was during my postdoc at UCLA doing research on cost benefit of addiction treatment and treatment for incarcerated individual. And I was just involved in what anybody who's going to become a professor would do in terms of teaching and research. When I found out the numbers that ended up completely changing the path for my life, and I want to start out by sharing that with you, because it came as such a shock to me when I was learning this in about 2009, 2010. It literally made me change my career. And the numbers were these. The numbers were the fact that 90% of people who need help for addiction don't get help. Um, by the way, based on SAMHSA data alone right now that just got expanded this year, that number is actually an overstatement of how many people do get help. The number has now been doubled from about 25 million people struggling with addiction to 40. I think that still underreports it to some extent, but it means now that about 95% of people don't get help. And I want you to understand how big of a thing this is. There is no other medical condition we know of where 95% of people who get diagnosed with a problem don't get help. Just as a frame of reference, in cancer, for instance, 80% of people who get diagnosed with cancer get at least one course of treatment. In diabetes, it's about 70. And if you're thinking to yourself, well, mental health is different than physical health, I'll tell you in depression, the number is about 60%. So in depression, 60% of people get help when they find out they have depression. In addiction, 5% of people get help. And I think this is the actual problem in addiction. It's not that we don't have techniques that work. It's not that we don't have tools. It's the fact that nobody who needs the help is getting it. And so it doesn't matter how good of a cure we have, right? I could have the cure for addiction in this mug. I've developed it over time. It works. If you drink from this cup, you will never have addiction. And actually, anybody you touch will never have addiction for the rest of their lives. It's magic. But I haven't cured anybody because nobody has drank from this cup. And this is the problem that we have right now in the addiction space. We have a lot of techniques that work, including some of the ones that we may not love all that much, right? Religious-based, 12-step based. I mean, think any technique, they work for some people, just nobody is getting them. So 90% of people, 95% of people don't get help. And the way we measure recovery right now, 90% of people who do get help fail within 1 year. Now, failure is based on abstinence here, but I want you to think about that. If 95% of people don't get help, and then 90% of people who do fail within 1 year, that means we're helping less than 1 out of 100 people who needs help in addiction right now. And when I understood that alone, I said, you know what? I can't be sitting on the sidelines and studying this anymore. I have to go make a difference. And so I left and I opened up a treatment center. That's actually when I met Claudia, when C3 was just starting. And we were offering, naltrexone referrals, at least for people, and working in that context back then, either daily or TSM based. But we were the only addiction treatment center, intensive outpatient in California that offered non-abstinence, moderation, and reduction-based help. The only one in California, which was insane, given the fact that it was 7-8 years ago. I think there are about 3 or 4 of them in California right now. But I've been on this mission for about 10 years now to figure out how to bring up that number of people who seek help. That's my goal. My goal is to take that 90% of people who don't get help and flip it on its head and get us to the point where only 10% of people don't get help for addiction. And I think this is where the synergy between C3 and Claudia's work and what Ignited does help, including, by the way, RIA Health, who I'm very well aligned with. So I call this online harm reduction, shame, engagement, and medication, or why we can't keep going the way we've been going unless we want to lose another 1 million people or so over the next 6 years. That title is not as friendly, so I figured I'll go with the first, but I think they both drive the point home. And so I told you already what made me stop being an academic, but before I stopped, because this number shocked me so much, I spent the next 2 years researching, well, why the hell don't people get help? I mean, that's insane. I knew I had an addiction problem and I didn't seek help until I got arrested. Why is it that a lot of us who struggle with addiction don't get help? And so this took me about 2.5 years to do the research, but I'll give you the Cliff's notes. There were 5 different barriers that we identified: cost, logistics, shame, abstinence, and negative sentiment about treatment. So let's go through these really, really quickly. It's probably not a surprise to a lot of you. Treatment can cost a ton of money, and not everybody has a bunch of it just sitting around waiting to get help. Even if you do, the logistics of getting addiction treatment for the most part are crazy. Think about the traditional way of getting help. You have to go away somewhere for 30 to 60 days. Who can take 30 to 60 days away from life unless it's a dire, dire need? I would argue nobody, let alone having to pay a lot of money for it. Then the next piece comes. Let's say you have the money and you can figure out how to take 30 to 60 days away from life. You now have to walk into a room full of people you don't know and admit that your life is terrible and that it sucks and that you need help. I don't know about you, but we don't live in a society. I don't live in a society where that is a very accepted concept, period. You can barely tell your friends and your family that life is falling apart. Walking into a room full of strangers is not a solidly recognized idea of functioning in our society. Even if you can do that, the only option that is presented to most people is abstinence. As we did, and we found out in our study, about 50 to 60% of people can tell you, I know I need to not do this as much, but I'm not ready to quit. So since 95% of treatment only offers abstinence, they're now ruled out of those 50 to 60% of people are ruled out of any options for care until they are ready to commit to abstinence. And finally, negative sentiment. The addiction field doesn't look good publicly. From old mistakes to therapeutic communities, which is the most embellished name for anything I've ever heard of in my life. If you know anything about old school therapeutic communities, the dogma and the hard edge of addiction treatment has gotten such a bad name for the entire field that nobody wants to visit it. So these are the 5 reasons why people don't go into treatment, and these are the reasons why only 5 to 10% of people get help at all. And so when I left the field, the academia field, I decided these are what I'm going to focus on. I'm going to focus on finding ways to reduce all these barriers. And that became my question. How do we create safety and reduce barriers to help more people, right? And I look at this globally, but we'll focus on the US for the most part. If we know that these are the reasons people don't go get help, we should do whatever we can to reduce as many of these barriers and essentially make it safe for people to seek help in a way that they like it. I think choice will end up mattering a lot here. And as we see, we're going to have to completely rewrite the old school ideas of what addiction help is even about. So I don't know if anybody has done a harm reduction overall kind of talk. I'll only go through it in a handful of slides, but I saw it in the original sort of conversation around the theme for the year. So obviously harm reduction has been discussed to some extent, but I got to tell you, times have changed. When I first started speaking on this about 10 years ago, the only thing people could think of when I said the words harm reduction were needle exchanges, which for anybody who doesn't know what those are, they are mobile clinics that go out into areas where people are using a lot of injection drugs. And then they offer clean needles and some cleaning kits to make it safer for people to inject. This was an incredibly controversial type of work, 15, 20, 25 years ago. But the idea was simple and relates back to what I started with here originally. And it's this: we can't help people who are dead. And so let's try to save them. Because if we save them, we may have a chance of helping them in other ways. So injection drug use is incredibly dangerous. One of the reasons because of overdoses we've seen more and more recently, but the other because of all the other conditions that you can get while injecting drugs with unclean needles in these sorts of environments. So the idea there, especially around HIV/AIDS, was to eliminate to the best of our ability the other conditions, the other health conditions that people might get with needles. But especially given the ideas we have about, I'll put this in quotes because I hate this title, but addicts, let's say, or alcoholics, the idea of making it easier for people to use or in any way agreeing or supporting the use of any drug by anybody who has a problem was blasphemous for the most people who were willing to work in this field. And so anybody who participated in these sort of harm reduction efforts was like a pariah in the field, to be perfectly honest. And when I'm saying this, like literally talks, if you wanted to present talks on harm reduction, they wouldn't be accepted. If you wanted to present papers or write books, nobody cared. It was a very, very difficult time to exist in that space. And I understand it, and we'll talk about it more. But the orientation I always had was this. We hear this idea of meeting the client where they're at all the time. And I used to use this slide when I would give harm reduction talks to professionals in the field. And I said, look, you all talk about meeting the client where they're at, but beating a client over the head and then dragging them over to your side of the street is not meeting them where they're at. It's forcing them to do something they are not willing to do. And the first time I literally presented this thing, people walked out of my talk because they were so offended by the idea that forcing people into abstinence is not potentially the best way to go about things, or forcing people into residential treatment is not the best idea. But I think that ship has sailed, and we've realized that those techniques haven't worked, right? More and more people are dying, as we know this from alcohol. we're going up, but we've tripled the number of deaths in the last 20 years or so from alcohol alone. We've quadrupled the deaths from other drugs. And so to me, meeting the client where they're at is really about offering the solutions people want, when they want them, in the way they want them. And while COVID was terrible for a lot of things, I think it was really good for this. And the reason was this. 3 years ago, so I started Ignited about 5 years ago, and we'll explain more about what that is later, but it was an online recovery support network, essentially. And 4 or 5 years ago when I started Ignited, people thought we were crazy. They said you can't offer people help online. They have to be accountable. They have to show up in rooms. They have to look you in the face. You can't trust them. And if you're going to try, it's just going to fail. Nobody's going to really be helped by it. But then COVID happened. And once COVID happened, people couldn't go to treatment centers, and you had to learn how to talk to them remotely. And yes, you couldn't verify if somebody was sober or drunk by giving them a breathalyzer because they're over there and you're over here. And so you had to start trusting people and creating completely different systems of care. And so over the last 3 years, not only did drinking double and triple in some communities over COVID, so the problem became much more wide, but also the solutions we had to employ were completely different. Treatment centers closed, jails opened, and people got out. The need for help was bigger than ever, and the old solutions didn't work. And I think COVID advanced our understanding of how we need to behave in this field by a decade at least, because it was necessary. So let's talk about some of the changes in what harm reduction can even look like when it's not in needle exchanges. So let's just to be clear, harm reduction is any public health policy that's designed to lessen the negative impact and consequences associated with different behaviors. By the way, eating, driving, a lot of other things, right? Anything that can cause harm physically or emotionally can have treatments or techniques in the harm reduction space. And around drug use, it's really a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Anybody here who's a TSM naltrexone supporter can probably already identify the role for something like naltrexone in the space. But let's start wider, right? Condoms are harm reduction. Seatbelts are harm reduction. Airbags are harm reduction. The pill is a harm reduction method. Why? Because there can be negative consequences associated with sex, with driving, and we want to reduce them to the best of our abilities, right? And so we do these things in order to reduce negative consequences. That's it. And I'll just make the flip right here, right? Welcome naltrexone. If you think about it, so naltrexone is a really funny medication, right? I learned about it during that same postdoc. So before TSM had ever really made a mark here, I was 2008, 2009. So I'd never heard of TSM. I never heard of any of those things out here yet. But I learned about naltrexone because of opioid research and opiate addiction research, which is how naltrexone came to be, by the way, right? So naltrexone became developed as a pill for opiate addicts to take, by the way, in very heavy duty, incarcerated, residential, low income sort of environments. People were given naltrexone before they left in order to reduce the probability that they will relapse and in order to give them a better chance of surviving. Again, right? A harm reduction method. If somebody used an opioid while taking naltrexone, it would block the effect. And we'll talk about how naltrexone works in a second, although I'm sure everybody here knows it. So it was great. It was a really, really great tool for opiates, except one problem: the vast majority of people didn't take it, because if they wanted to get high from opiates, they would just have to stop taking the pill for a day or two and they could get high again. But in the interim, while people were trying to develop better approaches for opioids, this really weird side effect happened. And that is, these people also drank less. And that wasn't part of the intended medication, but it started an entire path of researching why naltrexone could make people drink less, right? It wasn't exactly understood well at the time. But let's go back to why people don't get treatment. And I want to make it clear why I think naltrexone is such a beautiful harm reduction method. Let's go back to our barriers, right? The 5 barriers were cost. Well, naltrexone is a really, really cheap and affordable drug. So cost is substantially reduced for anybody who pursues it. Then logistics. I have to say we're not quite there yet on logistics, although the C3 Foundation definitely tries to make it easy. But it's much, much easier in a way to try to find somebody who will prescribe you naltrexone than it is to disappear for 30 to 60, 90 days, leave your work, leave your family, and go into treatment. So even though it's not perfect yet, much better. I am always flabbergasted by the difficulty of accessing naltrexone, given what the medication actually does. And to this day, I have less than I did 10 years ago, for sure. But I have clients who I tell about naltrexone, or they learn about naltrexone through one of our workshops on the Ignited platform, and they go to try to get it somewhere, and their family physician says, "Oh, no, I don't prescribe those kinds of drugs." And I literally had a client back in that treatment center about 6 years ago who went to their physician, and the physician said, "No, I don't give narcotics. I would never, subscribe that." And I really had to call the doctor, and I said, "I need you to look at the actual mechanism of action of this thing. It's like the anti-narcotic. It is literally the opposite of a narcotic. It does exactly the opposite of this drug you're so dangerous of." And so we had to go through a massive education campaign. And I know the C3 Foundation is big on that. But cost and logistics at scale should be a lot better for naltrexone than traditional treatment. Then shame. I already mentioned one of the hardest things for addiction treatment, and we'll explain how Ignited does it, but it's walking into a room full of people and showing your face and telling them that you struggle. Well, if you can get a pill that will help you struggle less, and it just comes to your home and you don't have to talk to anybody, obviously that addresses shame as well. Next piece is abstinence. And this is one that in most settings, I have such a hard time talking to people, because they will always go back to, okay, I understand that reducing is better than not reducing. But like in the end, everybody should abstain, right? And they always go to that. And the thing about the Sinclair method is that by definition, it doesn't ask for that, right? It doesn't ask people for that. And even the backhanded sort of language of, well, but in the end, you have to quit, still activates in people one of those big barriers. I'm not ready to quit. Don't talk to me about quitting. Help me drink less. And I think naltrexone does that incredibly. And then finally, negative sentiment about treatment. I'm not going to say that I love this aspect of medicine, but we definitely live in a time in our society where people would rather take a pill that will fix whatever is going on in their life than do work about it. It's just the way it is, right? We've become hack searchers, right? We look for any hack to provide us help with anything that we're struggling with. And naltrexone can definitely promise that, and for a subset of people actually delivers. And so the negative sentiment disappears immediately because somebody goes, "Oh, wait, I didn't know there was a pill for that." And immediately they are excited to seek out that support. So I'm just going to give you my impression based on the work I've seen over the last 10 years or so. And I think different groups will report different things on this. But again, I'm just going to give you my impression, having done this online and in person for a while now. Is the medicine enough, right? Is naltrexone alone enough? And I'm going to argue that it is not for most people. It's not. Now, again, we're not talking about perfect. We're just talking about a harm reduction approach. And so medicine not being enough, but somebody being willing to take it as a first step, I would argue is an incredible, incredible advance. Because once somebody says, "I will take this pill to try to drink less," they've now opened themselves up to other approaches. And I think that's incredibly important to hear. Based on my observation to date, about 30% of people get incredible effect from naltrexone right off the bat. Like they take the pills and they go, "Oh my God, I started drinking 1 or 2 beers instead of the 6 or 8 that I was drinking every day. And by the time I was starting my second, I didn't even really want to finish it." Somewhere like 30% of people that I've seen get that kind of help. Another 30% of people need more help. They need help. And I'll introduce what kind of help that is. Dosing, timing, the ramp up period. There are a lot of other, do I eat with it first or not? Some of those things I've found to be more complicated than sometimes are presented in the space. But those things can be incredibly helpful for somebody helping with dosing. But then there are other aspects like community support, right? Different people need different lengths of time for naltrexone, let's say under TSM, to be on board to get the kind of help that they are asking for, to cut their drinking in half, to cut it into, 30, 20% of what it was before. That initial time frame, when it's not as effective as they want it to be, they need support. They need to hold somebody's hand. They need to hear stories from others who have had similar experiences so they don't feel like failures because then shame kicks back in. And then oftentimes, still for those people, they need therapy, they need coaching, they need some counseling. There are other underlying issues that make it either hard to adhere to TSM, or as we've heard, and I'll introduce one of our people, well, a picture from one of our people is in his story later, Don. But while alcohol was not as rewarding or as pleasurable for him when he started naltrexone, it still really helped with his anxiety. And so he ended up using it almost as an anxiolytic, still drinking almost as much as he was drinking before, just having less of the pleasure response. So he really needed some therapy and some help around how to reduce stress so that it would work together with naltrexone for him. And I'll tell you, with those things combined, an incredible success story that I think needs to be shared more and more and more, that is a different version than maybe the classic TSM story that gets shared that I see it. You know, when you use a medication like naltrexone, you often need to be signed up for long-term motivation and commitment, right? You may think to yourself, I'm going to get the help I need within a week or two, but it'll take 6 months to a year. And that's a very different level of commitment, right? Signing up for a week or two intervention that will fix everything in your life is easy, and most people are willing to commit to it. But when it doesn't work 2-3 weeks later, a lot of people give up. And I think that's where you can combine with other support structures in order to help people find what they need. So really quickly, I think we already talked about it before, but somebody's explained this to you if you don't already know it. Naltrexone technically actually blocks mu-opioid receptors. Now, mu-opioid receptors are the primary binding source for those opiates that I mentioned before. So they work very, very well to stop opiate use, because if you have enough naltrexone on board and you use an opiate, you're going to feel essentially no effect, because that's the primary effect of opiates. Well, alcohol also activates mu-opioid receptors to a lesser extent than an opioid. But one of the things that it relies on is the cascading effect after mu-opioid receptors get delivered, which is of dopamine. So both opiates and alcohol do this. Alcohol relies on this mu-opioid to help dopamine release downstream. Well, naltrexone blocking this releases less opioids and less dopamine for people who struggle. And so that's where learning, dopamine is a reward neurotransmitter in your brain. So as you get rewarded, you learn what to do more of. As you get less reward because of less dopamine, technically you should learn to do that behavior less, because it's less rewarding over time. So that's why it takes time, and that's why it's not a magic pill that you take oftentimes and it cures you in one day. But I'll get back to those blocks we talked about. You know, naltrexone is not really meant to stop drinking short term. It's meant to change the way alcohol intervenes in your brain and the way it affects you. So it interrupts the cycle of drinking. And in that interruption, we get an inroad to long-term change. That is not the model under which addiction help operates traditionally, because the idea for most traditional addiction help is you have to do something that will stop people from drinking right away. So that's what works, for instance, or has been tried to work, for instance, in traditional addiction treatment. The idea is take somebody at home who's drinking too much, using too many drugs, whatever, move them into a house where nobody drinks, nobody uses. That stops the use right away. The stopping will already help. And then, yeah, we'll give them some stuff. Like we'll take them to 12-step meetings. If we're progressive, maybe SMART meetings. We'll have some groups in the house, and, we'll feed them nice food if they have money. So the idea is the stopping of the use is the primary tool. Well, naltrexone doesn't really do that. It interrupts the way alcohol functions in your body, and it gives you a little bit more control, a little bit more choice. And if you do that long term and do the other associated things with it, it should work. This is by definition harm reduction, right? Because we talked about the other options like seatbelts and condoms and airbags and things of that nature that also serve as harm reduction. But the idea for me is always this. This is somebody's status quo. This is somebody's current use level. And at the complete other end of it is abstinence, right? Now, the problem is most people try to get you from here, from status quo to abstinence as quickly as possible. The idea being that if we can get you here, it's safer and easier to keep you here. That system has failed over and over and over because people don't know how to maintain abstinence. They don't have the kind of lifestyle that can maintain abstinence long-term when they go home. And as we saw earlier in barriers, they don't even want it. So even if they go to a rehab and are abstinent for 30, 60, 90 days, in their head, oftentimes they're thinking to themselves, okay, I took a break. As soon as I leave, I'm going to have a drink. And I can't tell you the hundreds of stories I've heard of people leaving rehab, taking a cab and going to a bar, right? And so that tells us there's something wrong with this idea. And in the middle is harm reduction. Everything in the middle is harm reduction. Everything all the way from exactly as you are right now to complete abstinence falls under harm reduction. Harm reduction, the end of it can be complete abstinence, right? If you get to complete abstinence and you maintain it long term, the harm from alcohol is reduced, obviously, right? I want to introduce another part to this because this is the one that most people understand in harm reduction, but something I found that I never expected when we started Ignited a long time ago and started really doing a lot of harm reduction based work. And that is an area I call ignited abstinent, although I would argue probably Claudia and a lot of the C3 people would probably identify that also as a TSM abstinent. And that is people who just pretty much don't drink anymore. They stop drinking. They don't drink at home. Most dinners they go out to, they don't drink. But if they're in a special event or they have something they're going out to and they know there's going to be drinking, they may have a drink or two. And they don't see that as a problem because, again, it got them so close to the edge of the line. They're very comfortable here. And that is a part of the cycle, the harm reduction to abstinence sort of quantum leap that people don't talk about a lot, because the idea is that abstinence has to be maintained fully. But one of the things I like about TSM is the idea is always, look, for the rest of your life, if you want to have a drink again, you just pop one of these pills an hour or so before at your dosage and you should be fine. And so my whole goal in even presenting here, and we're doing this work forever, is I want to really figure out a way to meet people where they're at, right? So instead of having to drag anybody anywhere, you can say to somebody, hey, where on this continuum from where you are right now to complete abstinence do you want to get to? Oh, you want to cut your drinking by half. Okay, cool. Here are some options that we've seen help people cut their drinking by half. You're not fighting them at all, right? If you're fighting with a client or a patient, something is wrong. You should be helping them, not fighting with them. And so something like the Sinclair method and naltrexone really helps give people an option that is easy, cheap, shame-free, and that doesn't have the problem of kind of having them commit to abstinence from the get-go right off the bat. And I'll remind us again that part of the reason we're doing this is because we're trying to keep about 100,000 people alive every year. Forget the hundreds of thousands of lives we're trying to improve by having them rely less or feel less dependent on alcohol. But we're trying to save lives. And if you can take somebody, give them naltrexone, for instance, have them reduce their drinking and therefore reduce the probability that they'll do something else or combine drugs with alcohol in a way that will kill them, or just have an acute liver toxicity issue, you give them much, much more of an opportunity to be able to improve their overall life and work from that standpoint. So as I mentioned before, when I wrote the abstinence myth, I talked about naltrexone literally for about 3 paragraphs in the entire book, but it was just one of the options presented for people who are not ready for abstinence, but know they need to do something with their drinking. The reason I'm even talking about the book right now is, in an interesting way, one of the side effects of writing this book was I would get a lot of family members who would reach out to me and say, hey, my husband doesn't want to do anything about his drinking. He doesn't recognize it's a problem. My wife, my child, my sister, right? Whatever it was. And they would call me and ask for help. And the quick pill that I had oftentimes was just this book, right? Because the reason I called it the abstinence myth is somebody who doesn't want to quit picks up this book and goes, oh, there's something other than abstinence that I could do. And one of the reasons the Sinclair method and naltrexone was in there is I primarily work with people who are not ready to quit. And so I'm always looking for more and more solutions that can give them what they want, so I don't have to force them into anything. Because I didn't get into this space to beat people over the head and drag them into help. I know what it was like to struggle in life. I knew when I was struggling that life was not heading in the right direction, but I knew for sure I didn't want to go to rehab, and I knew I wasn't ready to quit all drugs and all alcohol forever. And so I didn't see any solutions for me. I didn't see any options. And I think in this space, what we want to do is we want to be the light at the end of the tunnel for people. We want to take people who feel bleak, who feel like they have no choice. Everybody from the mom who starts drinking at lunch because all her friends do, and next thing you know, she's driving intoxicated and doesn't really know how she got here, to the housewife, or the husband or the executive who ends up home and polishing off a half a bottle of scotch or 2.5 bottles of wine at the end of the night, right? These are not always classic alcoholic. God, I hate that word, but like, they're not always the classic people that we think of who struggle with alcohol, but they're everywhere, and they are not a good fit for the traditional way people get help. And so we want to be that light at the end of the tunnel. We want to be the people who help others find the sort of help they didn't even know existed. And we want to help them find it anytime they want it, in any way they want it. That's really the goal. And so I want to talk a little bit about the way I've gone about this over the last 5 years or so. And that was more technology based, but like with an app. And so we created an app that gives people workshops and coaching opportunities and recorded videos, including naltrexone workshops, because we thought to ourselves, well, if somebody needs help. I remember having these conversations with Claudia 7 years ago, 8 years ago, when the referral sources for physicians were really weak. And people would sometimes take weeks to be able to find a prescribing physician. And in the meantime, they still needed help, right? They're still drinking more than they want to. Their life is still feeling chaotic and out of control. And so I really wanted to create an option that would allow anybody, anytime, to get the sort of help they wanted. So we ended up going the technology route. But, when we talk about meeting the client where they're at, we're talking about people who are at work and need help when they're at work. We're talking about a single mom who cannot leave her child alone. She's got 2 jobs and a babysitter, and she has to be home when she has to be home. She can't go get help, right? Like something like the Sinclair Method, we want to be able to offer them something they can take when they have time, when they're available, when they need it the most. I mentioned I've been doing this for about 5 or 6 years, and a lot has changed in the last 5 or 6 years, just like it has for the Sinclair Method and C3. When we were starting to do this in 16, 17, and I would get on Zoom, nobody knew what Zoom was. Like, nobody in the world knew what Zoom was before COVID. It was kind of funny. But I would get on a group and I would lead maybe like 8, 9 people in a group. And this is what it looked like. It would be a video of me looking at myself, and then a bunch of black widows that nobody wanted to open up their window. Why? Remember that shame we talked about earlier? So I would just have people like, I didn't know what was going on with them, but we would show up week after week and support the people, even with their completely blank video screens, knowing that the fact that they were coming back every week meant that they were getting something at least out of it. And if you think about that, I don't even know that I understood when this started that all the tools that we assumed we would need for addiction help went out the window. I couldn't see what their face looked like in terms of were they drunk or not. I couldn't oftentimes hear their voice. They wouldn't even talk oftentimes. They would just type when they wanted to talk. Now, I'll tell you, about 2-3 years into it, a lot of people started sharing their windows, and now we're in a place where 60-70% of people have their windows open. But it gave us a possibility, right? People knew that they could come into a group with their window off, with their video off and their sound off, and they could still participate. And that didn't exist for in-person meetings. So just by necessity, because people were showing up this way, we had to introduce a lot of flexibility, right? Because we had to literally take people where they were. We oftentimes didn't know how they were doing in the moment. And a lot of incredible victories came out of that, because we were presenting material to help people with addictions. But really, we had to go based on what they were willing to do, because they weren't walking into our office. We weren't able to test them. And we just had to have real conversations about where are you and what do you want? And so in a real way, what ended up happening is we started asking people right off the bat. When people come to us, right off the bat, we ask, what are you looking to do here? So do you want to abstain is one version, but are you looking to just learn about your drinking? Are you learning to reduce it? Are you looking to get it into healthy limits? Or are you looking to abstain? Are kind of the 4 options that we always ask people. And it is a beautiful thing. When I worked in a treatment center, people had a really hard time telling you that are not looking to abstain. But working online in these environments, people are very comfortable saying, I'm not really sure that I want to abstain, but I know can't keep going like this. And there's something called motivational interviewing. And the idea is you're always looking for something that is akin to change talk. Somebody telling you they need to change is the first window you have to helping them change. And so this kind of conversation is really, really helpful because you get to say to the person, you may not want to quit, but you want to change your drinking. What does that look like? And with that, I want to just introduce the last kind of piece that I want to talk about harm reduction, because everything around harm reduction up until now talked about the use itself, but I'm going to argue there's an entire different level to harm reduction. And that is the other areas of your life that are being harmed by your use. And so I broke these down into 4 categories, and they are health risks, social consequences, the concept of self-determination, and your overall quality of life. I'm going to work through this quickly, and if anybody has questions later, I'd be more than happy to answer them. But the first one is health risk, and this does have to do with your use to an extent, right? Continuous abstinence, if you're able to maintain it, will reduce the health risks associated with your use. But so will relative reduction or relative abstinence. And I want to explain that concept, right? I'll introduce this guy, Don, later, but this story happens to us all the time at Ignited, all the time. Somebody will come in drinking 2 bottles of wine a night on average. That's about 14, 15 bottles a week. And then they'll work with us for a few months. And I'm sure this happens all the time in the TSM communities. And they'll go from drinking 2 bottles to like 3 glasses a night. So they'll drink a quarter of what they were drinking before. In traditional recovery, that is a failure. They are currently failing in their recovery efforts because they were drinking 2 bottles. They should be drinking 0, and they're drinking 3 drinks. But in the context of relative reduction, they've reduced their drinking by 75%. And I would argue that anytime you reduce a risk behavior by 75%, you are winning by all accounts, because associated health benefits from that. And so there are a couple of different ways we measure abstinence. One of them is relative reduction in quantity. Another is relative reduction in terms of percent of days abstinent. But people have a much easier time saying, okay, I don't have to abstain forever. I can reduce the amount, or I can have sober days in the middle of other drinking days, and it all works to help me. The next piece is self-determination. This is where I think the Sinclair method is so powerful, right? Telling somebody, you take this pill and it gives you some of your power over your drinking back is massive. Just for self-image alone, just to reduce people's shame. Because the message we get from society over and over and over is that if you have an alcohol problem, you're a loser. That's it. You're not in control of your life. Something is wrong with you. You're damaged. And the idea that you can do something as simple as, again, going to online meetings or taking a pill and get some of that self-determination back is huge. But in the context of addiction in general, there are a lot of other areas that people suffer that are related to self-determination. Housing, finances, they're just some of them. But these are other areas that can be really, really important for people, right? If your finances are suffering, you feel a loss of freedom and you need help around that. Obviously, if you don't have solid housing, you don't have reliable housing, that can cause massive problems in the reliability of what your day-to-day looks like, and can cause massive problems in self-determination. Then social consequences. We know a lot of people come to us because of relationship issues. The drinking causes problems in their family, romantic relationships, work relationships, and that's why they come, right? I went to jail, and that's why I went to get the help that I got. If somebody in my partnership ended up drinking way too much or using way too much, it would cause rifts and problems in my relationship. So oftentimes people come in because of social consequences, right? Criminal justice, employment, or relationships. But while they're looking for help with the drinking, if we can help with these areas of their life as well, they seem to end up doing a lot better. And then I'll produce the big one that we do. So at the Ignited, we have something called the Wheel of Life. And as you can see, it hits all these areas. So 10 different areas of life. And it says to people month after month, fill this thing out, tell us how you're doing. We give them a life score. I think mine would have started in the 20s, honestly. Now I'm in my 80s, which is really, really nice. But we also tell them, hey, here's where you're doing well. Here's where you need some help. Here's where you improved the most. And what people literally, one of our users emailed me the other day saying, I don't like tracking my drinking, but I love tracking my wheel of life, right? Meeting the client where they're at says, give them the help they need. Eventually, hopefully, they'll bleed into other areas. But the hope is that by doing this work, by having collaborative efforts across organizations and across treatment teams, et cetera, we can be collaborative with our clients and with the other people who help. We don't need to be antagonistic. We don't need to force people into doing things they don't want to do. We need to support them in the ways that they want to change. And the reason is, at some point soon down the line, they're going to hit a fork in the road and they're going to have to make a decision. And if you're the kind of person who always antagonizes them and forces them into situations they don't want to be in, they're not going to go to you. They're not going to get your kind of help. They're going to go to somebody else that doesn't feel troubling to them when they have a conversation, doesn't feel aggressive, etc. But if you can be the kind of support that they see as helpful, they may just come to you, get help for whatever they're ready to get help for when that fork in the road hits, and you never know the outcomes they're going to have. So I do want to produce one of our Ignited plus TSM success stories that I love, because Don, this is not his real picture. He's an older professor in his 60s. So I picked a picture because I don't want to divulge his identity, obviously. But Don came to Ignited drinking a fifth of scotch a day. And again, classically, as a guy who used to run a rehab, that is exactly who we would call an alcoholic, by the way, right? He was doing this for 15 years or so, almost always drinking a fifth a day. Classic daily heavy drinker that would be required to go to AA and traditional rehab. These are exactly the people that traditional rehab says are made for them. He joined us, and over the period of the first 3 months, he started doing naltrexone. That's actually how he found us. So I know Ria is one of the sponsors of this. He heard a talk I did with Ria, found Ignited through that, and decided to join us instead of Ria. But first 3 months, while on naltrexone, he kept drinking a fifth a day. 3 months. He was showing up to meetings. He was doing better. I don't know how many of you know somebody who drinks at those levels. When you drink at those levels, your tolerance allows you to pretty much be functional the entire day, even with those heavy levels of drinking. So it wasn't like he was slurring his speech, or he was functional and was coming to meetings all the time, doing the work for 3 months. After 3 months on naltrexone the entire time, he was taking it daily because he was drinking daily, but he was following the Sinclair method. He ended up taking on a 7-day sober challenge that we did. So he'd been with us for 3 months, not a single sober day during those entire 3 months. And then he decides to take the sober challenge. He didn't make it the whole 7 days, but he made it 6 days. These were the first 6 days Don was sober in a decade. A decade. He hadn't taken more than 2 days. Sometimes he would try to take a full day off, but it didn't always work. That was 6 days, 3 months after he joined us. Went right back to drinking. Now, I got to admit, as a harm reduction practitioner, it really hurt me that he went back to drinking, because I was hoping that he found his way. Obviously, there are a lot of health risks associated with drinking a fifth of scotch every single day. And I was hoping he had left that behind, but I'm a harm reduction practitioner. So that was the last thing I was going to do, was make him feel shame for drinking back. Went back. About a month after that 6-day experiment that he succeeded in, he said, I'm gonna do another period of abstinence. And this time he made it 14 days. So he went from 6 days, the first time in a decade he didn't drink for 2 days in a row, to 14 days within 5 months of getting help. Went back to drinking again. And then today is 29 days. So about a month after that last experiment, he said he's going to take another one of those sober experiments. He's now up to 29 days, literally as we speak. So in 5 months of help, he's had about a month and a half of sobriety. So about close to 30% of his time in the last 5 months has been sober. This is a guy who hasn't spent 2 days sober in 10 years. And this is why I'm telling you the story. With the right support and all the right tools in place, you can take somebody who, for all intents and purposes, looks hopeless to everybody out there. And if you practice patience and a shame-free approach, and you listen and support them as they are willing to be listened and supported, you can end up with a guy who's got a month sober. Tomorrow he's going to have 30 days sober without ever saying he wants to abstain long-term, without ever coming in for full abstinence, and without anybody ever pushing him into abstinence. And this, to me, is the magic of harm reduction. Because, of course, we want people to not hurt themselves, and not cause themselves bodily harm or emotional or psychological harm or life-based sort of, relationship harm, by overusing substances. But what we have to get through our heads is we don't get to control that. All we get to do is offer the right tools and offer the right support in the meantime. And what Don has showed us over time is that we can help with these kinds of tools. So people with us experience about 47% reductions in use within 30 to 60 days. And what they tell us, and I am sure that there are statistics like this on the Sinclair method, that they like us 2.2 times or 220% more than what they were trying before. And when you can combine these things, if somebody gets almost 50% reduction in drinking within 30 to 60 days, and they like the approach, they are more likely to stay. Like Don, they're more likely to battle through it. They're more likely to engage long-term in order to get the support and the help that they need. And so I'm not going to belabor this point, but we've seen hundreds and hundreds and hundreds of these cases. People saying this program helps me better than anything else. Oh my word, so much insight and knowledge I never knew. Super transformational. I'm a mom again. This woman literally lost her child, got emancipated from her, and said she would never talk to her again. And after 6 to 9 months in our program and getting her life back together, was literally able to get her daughter back in her life. Amazing at the results I've experienced. Now, again, this person was experimenting with baclofen, but people come to us with a camperset, naltrexone, baclofen, etc. And they've abstained for 4.5 months after 6 months of being with us. Like, the program doesn't make people abstain. The help is what makes people abstain. Again, Ignited has turned my life around. What a relief to find Ignited. We can help people without forcing them into anything. And that's why I wanted to speak here today. I love the Sinclair method for the fact that it offers people the kind of path they want. And then through the organization from C3 and other support communities can help them on the road to get them the success they actually want. So that is me. I know I talked a lot. I hope this was helpful. I think, Jenny, you said that if somebody has questions, we can stay around and answer them. If anybody wants to connect with me, those are my Instagram handles, Dr. Adi Jaffe and ignited.me. And then the Ignited website is right there, the Abstinence Myth book, everything else that you need.
All right, I'm going to go ahead and pop back on here real quick. All right, there we go. And all right, so we did run about 15 minutes long. I love that you mentioned your graphic on harm reduction and abstinence, because I have long said, mostly at addiction conferences where we are exhibiting, when someone says, oh, but harm reduction is just enabling. My go-to is that harm reduction and abstinence are not at odds, because abstinence is simply harm reduction taken to its fullest extent. They are on the same spectrum. And it was great seeing your graphic that talked about that. And one of our audience members said that what she calls the mostly abstinent, but only drinking on those rare occasions, she calls them Sinclair sober.
Yeah, I love it. I knew somebody had a name for it because we created one at Ignited for the same idea, but I love Sinclair sober.
Yeah, we didn't really have a name for it. Although what I have seen a lot now that we're in the 9th year of doing this, we're seeing what I call accidental abstinent people who come into the Sinclair method. They are 100% positive they are never going to stop drinking. It is not what they want. It is not among their goals. It's just never going to happen. And they're diligent with the Sinclair method, and they follow the protocol. And a few years later, after sticking with it and reducing and adding in more and more alcohol-free days, they'll disappear from the peer groups, and then they'll pop back in and they'll say, I haven't been in here for a while because, well, it's been 2 years since the last time I had alcohol, and I never expected that. And
Yep.
I just
Yeah.
went along with my life. Um,
100%.
so, it is so critical that if someone says that their goal isn't abstinence, don't try to force that on them.
Sure.
Maybe they'll get there, maybe they won't, but that's okay either way.
Yeah, 100%. I think all evidence in therapeutic communities anyway, sorry, I don't mean like the old TC addiction therapeutic communities, like in the therapeutic field, is that you work with people's goals. Here's the thing everybody has to understand. People are setting their goal right now based on who they are and what they see and how they understand life right now. So sometimes, and this happens to all helpers, sometimes you can see where they need to go. But if you jump the gun and try to take them there too fast, what you're doing is you're trying to push them to a place they're not ready to be at. So we get something like 40 to 50% of people who come from moderation and end up abstaining. It's a very common thing in our community. But if I told somebody, hey, look, you seem like one of these people who doesn't want moderation, who doesn't want abstinence in the first place, but then is going to commit to it later, I'm not accepting and I'm not talking to the person who's in front of me right now. And we wouldn't want anybody else to do that for us, right? Like we wouldn't want ourselves to leave college and have somebody go, I know you haven't had a job yet, but I see you as a CEO in the future. Let me just put you in the CEO seat and see how you do, right? Or I heard you want to take flight lessons. I think you're going to be a good pilot. Let's just go fly a plane. It doesn't work. It doesn't work in any other area of life. Why would you expect that to work here? If you take somebody who's drinking a fifth and hasn't had a day off in a decade and tell them they have to abstain forever, you're telling them they have to do something they haven't done in a decade and they have to succeed in it. They can't see an option for that being true. But now you take that same guy and in 5 months, he's at a month and a half sober, maybe 2 months, 3 months. I don't know how much he's going to have at the end of this road. You're not telling somebody who hasn't been sober for a year that they want sobriety. You're telling somebody who's been sober for half the year that they want sobriety. And that's a very different reality. Now he gets to make a very different choice. And I think that's the preview of harm reduction is meet people where they are, give them the help they want in order to fix the problems they know they need to fix. And once that relationship starts, you don't really know where it's going to go. And it's not really your job to push it where you think it needs to go. It's to walk hand in hand with the client and guide them.
Yeah, I spend a lot of time, especially with primary care doctors, equating weight loss with drink reduction on the Sinclair method because we all know that excess alcohol is dose dependent for health risks, and so is excess weight. And if a doctor has a patient who needs to lose 100 pounds, when I look at them and say, if your patient loses 45 pounds, are they healthier? None of them are looking at me and saying, no, they're not healthy at all. They're not any healthier. There are no because they know that there are fewer risks. Every pound somebody loses reduces risk at some level. Same as every drink someone decides to not have.
100%. And also, if you're gonna need to lose 100 pounds, then guess what? You have to lose a pound and 2 and 3 and 4 and 5. You have to lose all the pounds from 0 to 100 to get to a 100-pound loss. And if we count 0 to 99 as a problem, where's the reward? Where's the positive benefit and the positive sort of feeling associated with the winning that somebody is doing by losing 20 pounds? 20 pounds is 20% of the way to 100. There should be some celebration along the way. And I think you're 100% right.
And if somebody loses 45 pounds and the holidays come by and they gain 10 back, you're not going to look at them and say, you screwed up. You have to lose 100 pounds and you have to start all over from the beginning right now. You've lost all your progress, because that's just absurd. And yet that's what people do when they're treating people with addiction is, oh, you had that one drink. Yep. After 3 years of sobriety, you have lost all your sober time. That's just absolutely ridiculous.
Yeah. So we have, by the way, I mentioned relative abstinence. And so I have 3 abstinence tools that I help people understand they need to measure their abstinence by. Consecutive abstinence is great. If you want to use that as a tool, why not? It's a wonderful high bar of success, right? But then there's relative abstinence. So percent of days you've been abstinent for a certain amount of time. You just mentioned this, but if you didn't drink for 30 days and then you drank for 1 day, you're still 97% abstinent, right? For the month. You drank for a week, you're still 75% abstinent for the month. There's this thing called abstinence violation syndrome, which is once somebody goes from 0 to 100 in terms of their abstinence violation, they go, well, screw it. I already had the drink. I'm going to have to start from 0 anyway. Might as well make this one worth it. But that doesn't exist if you don't look at it as a black or white issue. You say, well, okay, I drank a day. I'm still 97% sober for the month. I'll start again tomorrow and I'll be back at 98 within a couple of days, right? Huge up factor. And then even for people who are unable to stay abstinent for a full day, if they can do what you just mentioned, drink 3 or 4 drinks less a day, 1 drink less a day, right? They can see that relative reduction in their quantity, and that is still a massive win.
Well, and this is where we encourage people often to switch up what they're drinking and to find a lower alcohol by volume drink, a lower ABV, because if you're somebody who, say, drinks vodka or rum and you have 6 drinks and then instead you have 6 beers that are 4.2%, you have more than halved your alcohol content with the same gross number of drinks.
Yeah.
And it's probably taking you a longer amount of time to drink them.
Yep.
And so it's a way of reducing things before you even start to think about doing things like habit change, trigger recognition. And if you can do those things that take little to no effort, then it makes it that much easier to put forth the effort on those other areas.
Absolutely. Absolutely.
Well, we need to wrap up for the day. So thank you so much for being with us on our final panel of our 3rd annual conference, day 2. Audience, you guys have been great. There are so many people out there from all around the world, and we appreciate all of you, and we will see you again tomorrow at 11 a.m. Have a great night, everybody.
Having me. Thank you, everybody, for being here.